Emerge owns the sins of the system. So where the system doesn't work, if you can't get a family doc, can't get post-op care, can't get care, you end up in the emergency.
This episode of Bring Back the Porch, brought to you by Bernie Leahy, River Street Realty. Let's get you home. Well, if you've been watching the news lately, you have probably seen lots of headlines, things like pure chaos, state of emergency, we're getting crushed, daily carnage, all referring to the situation in the hospitals in Alberta, particularly in emergency rooms. Dr. Paul Parks joins us now, and I'm appreciative of your time, sir, to talk about what's going on in Alberta.
Yeah, happy to be here. I think we got to talk about it much more, so all Albertans everywhere have at least a start of understanding of what's going on.
You have been talking about this for more than just 2 weeks. You have been talking to anybody who will listen for a long time now, and it unfortunately took a couple of deaths in Edmonton emergency rooms to maybe get the attention of mainstream media. Can you go back and sort of go to a point in time where you think we took the wrong direction when maybe all of this started to fall apart?
Yeah, well, how far back do you want me to go? I mean, one of the troubles, I can give you a nutshell of that. I've been in Alberta. I trained here. I've been an emerge physician since 2005, did my training from 2000, worked in Edmonton, big issues there, came down had been down here since 2009, haven't looked back, love it down here. But there was a time where we were having a lot of the issues around capacity in the system, workforce, and how the system works. So Emerge owns the sins of the system. So where the system doesn't work, if you can't get a family doc, can't get post-op care, can't get care, you end up in the Emerge. And so we see Frontline a lot of the places where a lot of the areas in the system that don't work. And in the late 2000s, I collected a bunch of cases, examples, brought it to the attention of the government, made a big, pretty provincial fuss, and we actually made lots of improvements. And over that 10 years, say, call it 2010 to 18, 19, 20 in there, but what we did is optimize the system, made things better, surged in areas, used all the elasticity and any kind of efficiencies we could gain. We got all that. Then we went through a tough pandemic. And then after that, I got to say, one of the things is in the background, this government has inherited, the current government has inherited a lot of neglect on planning around workforce and a lot of neglect around planning on capacity for our acute care hospitals, how many hospital beds are we going to have per capita, but also our long-term care and continuing care. And a lot of that stuff got neglected to the point where now in the last 2-3 years, getting harder and harder to get people in the system. I'll always say it because I'll probably talk about a lot of negative things here. I'll say off the get-go, if you can get into a system, you get some of the best care in the world. Mm-hmm. Still get it. It's the getting in that's really hard. And fast forward to what really changed a lot in the last couple of years is got a new government in, inherited a lot of problems, but this government actively dismantled our provincial healthcare system and made a bunch of changes and broke it up into 4 silos. We got 4 ministers now. There's acute care, there's long-term care, there's Recovery Alberta and mental health, and then there's primary care. 4 new ministers, 4 new CEOs, 4 new administrations. Actually, it's 11 CEOs because they forgot about cancer care and public health and you name it, all that. They really broke it up and separated it to the point where we come to here now, been advocating really hard for the last couple of years. Let's improve the foundation of primary care, get everybody family doc, work on that. But also said at the same time in 2023, gave them a plan and saying, hey, we have to do some serious stuff on our acute care hospitals to make sure they're functioning, make sure that we can do safe and timely care for all Albertans when they get sick. And sadly, government didn't move on that and didn't work on it and kind of just kept going on breaking up the system and reorganizing it to the point where in the last year, we've been redlining. So anybody out there that hears that this is just influenza and that this is just a little blip because of influenza, I'll just tell you, influenza is probably like 1,000-pound brick that landed on the broken camel's back already because we were really struggling for the last year and really begging the government saying, listen, we need some kind of organized provincial control of this and really start focusing on things. And then we got slammed by the increased volumes in respiratory illnesses that we knew were coming. We knew this was coming. I mean, we saw, everyone should understand that we see the influenza hit in the southern hemisphere in the summer when it's our summer, their winter. And we knew this was going to be bad and we begged them for help. And then sadly, it just got to the point where we really got to the point in Edmonton, for example, where if you think about it, let's simplify numbers. At one point, Edmonton has 275 emerge beds in care spaces where they can take care of 6 people. In December and into now even, there were times where there were 250 admitted patients. So sick patients with strokes, cancer, broken bones, you name it, surgical emergencies, heart attacks, stuck in the emerge. They were 250 of our emerge beds were for patients that should have been up on the wards, taken care of by specialty teams. The wards are overflowing. The wards were having rooms where there was, if a room was designed for 2 people, it's got 4 in it. If it's, we literally have patients stuffed in cubby holes up on the floors, where I'm not even making this up. I'll tell you, we have patients in some rooms where there's no call bell, and they have it like a ding-ding old-fashioned bell to try to get the nurses. Yeah, so we got to that point where there was just no more give. And if you think about that, just think, Edmonton's own probably didn't, even 270 beds is not quite enough to take care of all of the emerge patients for Edmonton and everybody coming into from Red Deer North, all the way to the Northwest Territories. And 250 of them are taken and gone, right? You're operating like an entire, 2.5 million people plus more area out of 20, 30 emerge beds. And that's where we get to. My colleagues across the province have been saying, it's not just Edmonton, Calgary. I just got off the phone with colleagues there. Never seen it this bad. Never seen it this overcrowded. And what that turns out to be for everybody to understand why we're talking about it, why we're saying, there's a lot of semantics around declaring a state of emergency, for example. We're not saying you got to bring in the National Guard and the feds and the Army and or implement pandemic measures where you can't go out and do things like. We're not saying that. We're saying we're in a state of crisis and an emergency or a disaster where we need provincial control and we need coordination. And there's lots of things that we can do, but we need to make sure, we just got to kind of define it. Say, yes, it is a state of crisis. Yes, we are having trouble. And then we need to say, who's going to kind of come, if you think about it in a disaster, if a plane crashes, anything happens that's big, multi-casualty, you define one person. You're the leader. You're going to get your team around. You're going to control this. You're going to actually make sure you're empowered and resourced to take care of it. And then you're going to kind of mitigate, and do the best you can. We haven't declared that in the province. We haven't got any one leader. We haven't got the government saying, yeah, it's real, and here's how we're going to get out of it. So that was a long answer to say, 15 odd years of, we made some improvements. We got better. The last couple of years, I got to admit, it's been the hardest any of us have ever seen in the last little bit.
As I looked at some of the articles, it occurred to me, to use a medical term, the system's constipated.
Oh, yes, absolutely. In fact, and that is one of the things that it makes it very hard. When I say that they broke up the system, for example, there's a minister of assisted living now, and that is the Minister Nixon, who's in charge of continuing care. So anything that would be ongoing care needs, whether it's home care, nursing home, all the way to full nursing home or assisted living, and that's its own silo now. But right now, currently across our province, anywhere from a quarter, 25% to 33% of our hospital beds are occupied by people that have had care, got admitted. Say, you can picture someone's grandma gets pneumonia, lives at home alone all by herself up until then. But then because of the bad pneumonia, can't really move well now, has to use a walker, can't go back to her home and needs to go to assisted living. Maybe not full nursing care, but needs some assisted living. We have about a third of our hospital capacity are those kind of patients that are stranded in the acute care hospitals across the province. And they're stranded there, I'll say, because once they get designated alternate level of care, we call it, they start getting charged. So they get actual charge for being in the hospital. And then they're stuck there and they can't mobilize, they can't interact with people. They don't do as well as they would if they were out. And because we don't have the community's resources of home care, assisted living, or these long-term care beds, the solution to fix our acute care problems and the constipation, the thing to get us, disimpacted and get rid of being bunged up, that lies in a different ministry now. It's fully over in a different spot of the system. And we're crying for a crisis here and saying, yeah, we're constipated. We really need to get things flowing. We got to get things moving. But the solutions are over with somebody else that doesn't feel the pain or the tummy ache or the need to go.
Yeah. You referred to silos, and I'm wondering if that puts different ministries in competition with each other.
It absolutely does. In fact, that was the very first thing. So I got to say, I had the privilege of being the president of the Alberta Medical Association. I was there for, through 2003, 4. I was literally there as the new minister came in, new government came in. And I was one of the first people that got shown this silo and this organization that they were going to create, break up AHS. I got to say off the get-go, was AHS perfect? No. There were lots of things that could have been improved. In the hat here, I could tell you, for example, could we have had a bit better local decision making within the AHS beast? Could we have said, hey, this works well in the hat. Let's implement this. We don't need to do what Edmonton or Calgary does. We could have improved that without blowing AHS up. Mm-hmm. But they blew up AHS. And then and so what that set up now is once they put these four different silos now with 4 different ministers, and then we come out and say it's a crisis. Well, essentially they set up a scenario where the minister of assisted living is not going to say, hey, it's our fault. Yes, it actually is these patients that are stranded in the hospitals that should get out. And meanwhile, it'll be the minister of hospitals is going to be, well, it's these people, it's theirs, and they're going to blame each other, right? And when the solution is to coordinate, but it even gets to where they start gaming, where we've seen a drop of about 20% of our ALC numbers. So again, ALC, I hate all the acronyms we use, and it's
like the Army.
It is. It truly is, and we have to because it's a complex system. But that is the stranded patients. That's your grandma stranded in hospital, and we can't get her out because we need assisted living, for example. Those patients are, we got a 20% reduction of them. But when you look at it, you're like, well, is that because they moved out of the hospitals, or did they redesignate a number of them and change the designation? It's the latter. They didn't move out of the hospital. They just changed some of the designations of people. So let's simplify that, and really, why would they do that? And what they did is, over in the Ministry of Assisted Living, they're like, well, we're going to look at all these people that are listed and see if they have a little bit of medical conditions, or they still have a little bit of things that are problematic that still need to be dealt with. We're not going to let you call them ALC anymore. And what that turns out to be, though, is kind of being like, well, we got my grandma who had pneumonia is better with pneumonia, but she's always had diabetes and she's always had hypertension, and that can be treated in the community. But all of a sudden, Minister Nixon and his team want to say, no, we can't take them out till you fix their diabetes or hypertension. So it set them up to compete against each other, and it set us up to fail right now.
I can recall a time when every hospital, Medicine Hat Hospital included, was autonomous. They had their own hospital board. They got their money from taxpayers in Medicine Hat. I don't recall people complaining about that at that time. So when they moved to this centralization, was that maybe the wrong thing to do?
Well, yes and no. So there are 2 pieces to there. So healthcare has become so complex that you can't do it in an isolated hospital-based method anymore, right? Part of it is just our big patient volumes across the province. So geography's against us. There's also super specialization. So you're never going to get, as examples, if you have a heart attack here, we need to see you and emerge, stabilize you, but you got to go to the heart. You got to go to the heart specialist in Calgary. So there's certain pieces of the healthcare system that we know needs coordination and integration and works better with that. On the flip side, one of the criticisms, very valid, of what was happening as AHS got bigger and more provincial and more integrated was that we started losing the voice of some of the regional hospitals and areas of like I said, saying, hey, here's something we do really unique in our community that really works. We want to keep that, or we want to build on it. And we started losing that. So what happened though is, and it's always this crazy pendulum swing of, okay, we got this great integrated system that has some problems. Let's just blow it up and totally disintegrate it. When in reality, what we all would have advocated for, and the experts that are on the front lines would say, let's keep the integrated pieces that are really working well. Some of it is like having a command and control structure of how are we going to share resources through the whole province. Keep that, but let's improve some of these local decision makings. And then exactly what you said around, and it is coming up a bit with the government, but you can do certain things where the funding for the areas is controlled better by the areas. Mm-hmm. And so there were things we identified. But now when you cycle back to this crisis that we're in, here's a perfect example. So Edmonton corridor or zone, they've changed the name to corridors now. Even they love changing names. They love it. And I get confused. And sadly, I don't even know if it's corridor or zone yet. And then sadly, I don't know who's leading it. And I work in the system and I'm navigating it. But picture Edmonton which takes a lot of out-of-patient transfers, because anybody that's sick that needs higher level care from Red Deer all the way to the territories, even northeastern BC, northwestern Saskatchewan comes into Edmonton. It's a big area. In fact, if you look at it provincially, Edmonton area takes 4 times more of out-of-zone transports than any other zone, which would be Calgary. Mm-hmm. So that right now, Edmonton zone saying, hey, we're in a crisis. But you can picture someone in Hinton or Fort Mac or up in the Northwest Territories is very sick that has to come into Edmonton. Because they totally disintegrated it, there is now nobody that can kind of say, I'll even make it even clearer for everyone's listening. There's 5 major hospitals in Edmonton. What's been happening in the last 4 weeks is picture someone sick in Hinton, dying, and really needs extra care. The doc in Hinton be like, I can't manage this patient. I'm stabilizing them. I got to get them to Edmonton. They'll phone the U of A, get an emerge doc on there, an internal medicine specialist, and they'll say, hey, we're full. We can't safely take you. Try another hospital. Phone the Royal Alex, same answer. Phone the Grey Nuns, same answer. Phone, Misericordia, same answer. Phone the surgeon, same answer. Gone through all 5. Now you've got, and now what was happening is they would just be like, the person that was coordinating the call would be, U of A, you just got to take it. Doesn't matter if it's safe or not. And we transfer them in, and we do our best. And they would sit in the hallways. And sometimes they would have bad outcomes, and sometimes they would die. Yeah. And we were telling them that this was happening. It got to the point where now you think about this person in Hinton, all of Edmonton saying, can't take it, and we can't force them in there. There's nobody to coordinate to say, hey, that patient in Hinton should be able to call Dr. Parks in Medicine Hat and the internist in Medicine Hat, and we can say, hey, we're doing okay right now. We have a couple extra beds and someone's dying. We can fly them down here. And we used to do that regularly as a big integrated provincial system. And that's just one example. There's other things we could do in a coordinated manner that disappeared because there's nobody. And so here, I want to just say, so there's going to be people out there listening and saying, there's no way that disappeared. That couldn't have disappeared. I got to tell you, we not in the media. We advocated internally. Hundreds of doctors signed an op-ed saying we support this is chaos. We're in trouble. Mm-hmm. It's not just Dr. Park saying this. We advocated within it. No one could identify who's the person to help us with that example, for example. And then we go in the media, and it comes out, and people learn about patients dying, and it's really bad. And then it takes them 10 days to figure out which minister to answer that criteria. And even still, we have this acute care Alberta, and the CEO comes out and says, well, we're kind of working on that. We're kind of responsible for that. But in real time, in the day, when you have someone dying in Hinton or dying in Camrose or dying in Brooks, and they need to go somewhere, you can't rely on it going up to some minister, 4 ministers of health, having them figure out and having... That's how broken the system is.
Yeah. We need someone to triage the system.
Yeah. And it's sad. And then I really want to highlight, so people understand, like, I'm in Medicine Hat, again, we were talking a little bit. We're a little bit of hidden gem, so we do have some troubles. I know, don't tell anyone. We are still able to manage our bed base and getting sick patients in, and we're still managing some flow. We have some days we struggle, and we have some days where people will wait 8, 9, 10 hours in our waiting room, for example. I get it. Nobody likes to wait. Like, I don't like it. Nobody. We would never do that to people if we had the resource that could move people thing. But one of the reasons that is some examples we'll get challenged with is that, say, Calgary gets really swamped, and then we have a patient that has a specialized stroke or a specialized surgical complication or a heart attack that needs to go to Calgary. We can't send them there. And then we got to spend longer with them here. We got to keep them, and then we can get backed up a little bit. But I want to say that we've managed to kind of be hidden a little bit here and managed to be able to deal with it. But as this crisis grows more and more and more, it's going to impact the whole system.
It's going to spill over here. And
that will go back to your question that you said a little bit about that's kind of why I want to just highlight when you hear now of one death, like the tragic death of Mr. Sri Kumar. Very public. What I wanted to kind of say is that it's hard to fathom maybe if you come to our merge and wait 8 hours and are frustrated, but you're like, well, if I went there with chest pain, they get me in an hour or two. And I can't fathom why they would leave someone out in the waiting room, 44-year-old with severe 10 out of 10 chest pain, have to paint the picture that on that day in that emerge, if they have, say, 50 beds that they operate, 48 of them had sick, dying patients already admitted. And they're working out of 2 beds, and and they probably had 12 patients with chest pain in the waiting room. And and someone with a stroke in the waiting room, and then someone comes in with a breathing emergency, so they get the next bed and that patient waits. That's the kind of environment we're looking at day in and day out. And once that environment gets so difficult, triage breaks down. Triage is the French word to sort. It means I'm just going to have a really good emerge nurse look at all those 20, 30 people out there and say, I think you're sick, so I got to get you back in next. It breaks down, though, when there are no next beds to put them in. Yeah. Then you just identify a whole bunch of people that need beds and be like, yeah, I can't do anything for you.
What about the people who are on the front line? How are they holding up?
I got to be honest, it's very demoralizing now, and burnout's growing. And a couple reasons. One is that I'll actually go out on a limb and say there's nobody that goes into healthcare and wants to see people suffer and not intervene. Like you can picture how some people might over a long time get a little jaded and a little bit harder, but nobody wants to see that day in and day out. And I can tell you, like, a good example, reaching out to my triage nurses across the province in some of these really bad emergencies, it's the worst job in the world. I don't think you can imagine what it's like to see, because if you think about 70 registered patients in your waiting room waiting to come in, and then 1 or 2 family members with each of them, and each of them coming up and pleading. And I want to say, too, not everything's life and death. You have people with 10, we see people with broken bones and their ankles kind of sideways, and we can't even give them pain meds for 10 hours, say, right? Like that would be a hard job to do day in and day out. So it becomes really, a lot of moral distress. And so we're losing a lot of our really good healthcare workers now because they're leaving, because they're saying, listen, I can't function in this current system. So they leave. That makes it worse, because then you've got hard environment with even less team members, right? And then so moral distress is big. The burnout is increasing for sure. And then again, you got to add, when I want to stress, like, one of the things the government did, this isn't ideology, this isn't if I vote right or left, they came out and said, we're going to disintegrate the system, we're going to change, but it's been 3 years of change, and it's been chaos. And if you don't know how to navigate the system day in and day out, now we have nurses, for example, that don't even know what silo they're in. So picture your a mental health nurse, and you can picture how there's mental health facilities in the hospitals that would be under acute care, or maybe you're in Recovery Alberta, or maybe you're one of those nurses that works out in the community with primary care in mental health. They don't even know who they're reporting to, or who's paying their check, even to a degree. Like, it's that chaotic. So adding that distress and the burnout and then the chaos, it's got to stop. We got to give us some. Otherwise, what happens? We're in a scenario where there's a national and worldwide shortage of healthcare workers. They can choose where they want to go, and we're really struggling to recruit in an environment where, who recruits healthcare workers, doctors, and nurses to the Medicine Hat? It's the people working here and saying, "Hey, it's good here. Come on down and work." Yeah. As soon as you lose that, it becomes really hard to overcome.
That's what I was going to say. Like, anybody who would just be graduating from a medical school or a nursing school, looking at a place to go, and they look at the system and they see the news in Alberta, I'm not going there.
100%. And then we're eating our young, because now we'll see, I don't have the stats in front of me, but you can look it up, is that, it's almost like about 42% of our nurses that are trained, go on to a different career or move out within 5 years. It's that difficult of an environment. So I don't have the number, so I don't want to get quoted, but it's so high that it would make you be like, oh, geez, that's like, because we spend a lot of time and effort to train people, and so you want to create an environment where they're happy to work in, right, and where they feel like they're making an impact. So,
what can our audience do to help keep things out of the emergency room?
So I want to say there's a couple interesting things. I mean, part of this I'll say is, and it gets conflated and confused a little bit. Most of the times when you're looking, if we could get everybody a family doc and have robust primary care, there's 2 concurrent crises in Alberta and all of Canada in a way, is that there's far too many Albertans. It's almost 1 million don't have family doctor and don't have a regular, someone that can kind of keep you healthy and do your kind of see you in 24 hours if you have something come up. And so we need to fix that, but that won't necessarily solve what we're talking about here with the crisis right now, because the crisis right now, and I want to be really clear in our emerges, is that we can't see the sick and dying in time. And the sick and dying can't be taken care of by our family medicine colleagues in the community. They send them into us, right? They call me and say, Paul, I got this patient with bad chest pain. Can you see them for me? That's my job. That's how it works. But they can't help us with those sick and dying patients. So the solutions to fix that piece are different than the solutions to fix getting everyone primary care. So I will say that there's a bit of misguided, and the government likes to latch on around trying to think about just redirecting sniffles and lumps and bumps and things like that away from the emerge. A lot of times if we made some robust options for everybody else, that would help a little bit. But in reality, I think a couple things that I can stress is that if you are sick, be patient, come see us. And it's hard to tell sometimes, is that chest pain or indigestion or what is it, right? That belly pain you got, so just be patient with the teams that are there and understand they're working hard. But I think the other thing I would say, and this is why I'm talking about it, is I think we all have to start talking about healthcare. And we all have to say, and we also have to start having conversations again about taking out ideology. Let's not talk about, I've always voted conservative or always voted NDP or whatever. It's like, is our healthcare going in the right direction? Is it going the way that we think we want for us and our loved ones? And start having that conversation, but then start saying, if I'm concerned it isn't, then we have to start getting active and mobilized and start talking to our MLAs and start talking to our government, because they're the only ones that, it always seems partisan to criticize what the healthcare system's in right now, but there's only one government that runs it ever, right? So we need people to add their voices to this, because I want to say, I haven't touched, like for our community, where you're going to see troubles are, if we don't do a really, coordinated workforce planning, capacity planning, we hear of Bow Island's lost their emerge docs all the time, and Bow Island closes. We're gonna get to where we might hear Brooks is closing, and Brooks emerge might not be staffed anymore, or Oyen, might not be able to get staff in it anymore, and these communities that feed into our community, and that's a double whammy, because then anybody living around here, when you lose your hospital or your emerge access, and you don't know what you got till it's gone. Yep. And then once it's gone, it's almost impossible to replace. It's really hard to recruit nurses and doctors into a hospital that hasn't been functioning, for example, or a community that doesn't have support. So once you lose it, you're in danger of losing it for a long, long time or forever. But the second is then that impacts the communities around you, because all of a sudden, the only places you can go is Medicine Hat. So in our community, so when Bow Island's closed, if Brooks went down, if others around, everybody's got to come here. And again, that just adds more volume and more complexity and more weights for everybody in one center. And that's not what we want. Everybody should have. I think as a society, we should start to prioritize and say, here's some of the minimum things we should have, that we should think you should have in reasonable sized communities, and we should protect that. Like, for example, in the Hat, we had a couple months ago in the last year where we had no obstetrical coverage in our entire, so in no obstetricians in our hospital to be able to deliver babies for the sick and complex. We had family docs that could, but our obstetrical specialists weren't here. But that's kind of mind-blowing, because that's not just for that, that's for the entire surrounding area. And that means young, healthy women who may have complicated pregnancies, like twins or things that we know are going to be complicated. They got to travel all the way to Calgary to deliver their babies, as an example, and you don't know when they're coming. Like, it's those are the problems we got to deal with.
And Calgary might not have the room either.
Well, in this state where we are right now, absolutely not. They're going to struggle. It's going to be tough.
Patients, when they're on the table or the gurney, you don't ask what their political affiliation is.
No, yeah, 100%. And that's where I hate being the kind of bearer of bad news, in the sense of, like, being the person always kind of saying and stressing where the system isn't working. Because again, I'll say, when you get in, it's amazing. Like, I'll give an example. In the last, couple of weeks, I've had in my team in Medicine Hat where someone come in and with crushing chest pain, maybe similar to the tragic case we heard, that gets seen in 10 minutes, gets clot busters in like 15 minutes, like specialized, and is transferred to Calgary within 90 minutes and is on the cath lab table getting, a stent in hours. I mean, it's phenomenal what we can do when we have that flow and it's working the way it should. And our teams are amazing. They truly are. And my colleagues are amazing. It's that once the system constraints and once we get so constipated and things don't work and flow, that's when we can't do our job.
Dr. Paul Parks, I appreciate your time.
Yeah, I appreciate being here, and I appreciate the chance to chat. And like I said, I think if I'll put a plug in again just at the following at the end, is that we are a little hidden gem doing good, but I think we're doing well here, but we all have to add our voices and start talking about this and start thinking about, and when healthcare workers across the province raise the alarm, I think we got to listen.
When you go into the emergency room, it's too late to talk about it.
That's right.
Thank you very much.
Awesome. Thank you.